Bismillah ar-Rahman ar-Rahim. Hello everyone. I am Professor Dr. Mohammed Ayman Abdul. I am Professor of Cardiology in Alexandria School of Medicine, and I am a consultant in the Adult Echo Lab in our faculty. Today I'm going to give you a basic review on aortic valve stenosis. To start with, the epidemiology. Aortic stenosis is the most prevalent of all valvular disease in developed countries. Actually, aortic stenosis is much more prevalent in the old age populations. As you see here from this figure, we are going to find that there are more prevalent aortic stenosis among those who are old. So for the etiology of aortic valve stenosis, we have three main categories. Aortic stenosis could happen in the young populations in the form of congenital malformations of the aortic valve. The most common one of them is bicuspid aortic valve. In the middle age, you might encounter aortic valve stenosis secondary to rheumatic heart disease. And in the very old population, you can see senile degenerative aortic valve stenosis. So starting with the congenital malformations, the most common one is the bicuspid aortic valve. As you see here, this is a transesophageal echo, and you can see here that this aortic valve is a bicuspid one. The incidence of congenital bicuspid aortic valve is around 1% in the population. This bicuspid aortic valve might be associated with some aortic dilatation in some patients, and sometimes it might be associated with coarctation of the aorta or the presence of a subaortic membrane. So whenever you are going to be, whenever you encounter a patient with a bicuspid aortic valve, please check for the presence of aortopathy, the presence of aortic coarctations, or the presence of a subaortic membrane. The second cause is a rheumatic. Actually, rheumatic aortic stenosis is declining in the developed countries, but it's still a major problem in the developing countries. Rheumatic aortic valve stenosis is commonly associated with mitral valve affection. As you see here, we have a thickening of the mitral valve and lack of systolic coaptations with the limitation of mitral valve movement, posterior leaflet movement. So this is a rheumatic touch of the mitral associated with thickening and limitation of systolic excursions of the aortic valve. The third type is the degenerative, what we call it senile calcific aortic stenosis. It's more prevalent among the old age, more in males, those who are hypertensive, hypercholesterolemic, or smokers. And you commonly find this type of degenerative aortic stenosis in patients with chronic renal failure. Going to the natural history, patients with aortic stenosis may remain asymptomatic for a long period of years. And at a time in the natural history, those patients start to complain from symptoms of heart failure, angina, or syncope. Once symptoms starts in patients with aortic stenosis, the survival rate declines steeply, and this put the patient at a high risk of death. Aortic valve replacements, whenever symptoms starts, have a positive effect on the outcome of those symptomatic patients with severe aortic stenosis. Aortic valve replacements improve the survival, improve the ejection fractions, the NIHA class and it regresses the left ventricular mass. Then, who are the high-risk aortic stenosis patients? Based on echo data, we have 2 points here. The very severe aortic stenosis is considered whenever the peak systolic velocity across the stenotic valve is more than 5.5 meters per second, or such Vmax is rapidly increasing in severity with a rate of Vmax progression more than 0.3 meter per second per year. Also added to the high-risk aortic stenosis patients are those patients with aortic stenosis plus concomitant coronary artery disease, or those with aortic stenosis and having depressed LV systolic functions, or if there is an marked left ventricular hypertrophy in the very old patients, or these patients with aortic stenosis and a positive exercise test, and those with aortic stenosis and non-cardiac comorbid conditions. Then how to assess the severity of aortic valve stenosis? I mean the quantification of aortic stenosis. Echo is the golden standard for assessment of severity of aortic stenosis. We have here a criteria for severe aortic stenosis. AS is considered severe whenever the peak jet velocity is more than 4 meters per second, or the mean gradient is more than 40, the valve area is less than 1, or the index valve area is less than 0.6 square centimeters per meter square, or the velocity ratio is less than 0.25. This is an example of a patient with severe aortic valve stenosis. As you see here, this is the LV response to the aortic valve stenosis, where we see here that there is a concentric left ventricular hypertrophy, and the ejection fraction here by eyeball assessment is preserved. The estimated ejection fraction is 65%. Here, the peak gradient across the aortic valve is 135 millimeter mercury. The mean is 86, and the estimated aortic valve area is 0.7 square centimeter. So this example, the patient have a severe aortic valve stenosis because the area is less than 1, and the mean gradient is 86, meaning it's more than 40 millimeter mercury, and the peak velocity is 5.8, more than 4. So this is a severe aortic valve stenosis with preserved ejection fractions, and there is a gross left ventricular hypertrophy. Then how can we calculate the aortic valve area? The aortic valve area, we can get it from the 2D by the use of the continuity equation. We apply the continuity equation. First of all, we are going to use a pulsed Doppler wave to get the time velocity integral of the left ventricular outflow tract, and CW across the aortic valve, we get the velocity across the aortic valve, and we measure the left ventricular outflow tract diameter. We apply these 3 numbers, and the machine automatically is going to get the aortic valve area for you. There is an additional value of the new 3D echo. Actually, 3D echo can give you a precise assessment of the aortic annulus diameter, and it can allow you to directly measure the aortic valve area independent of the continuity equation, direct measurements of the area. So this is a 3D volume for the left ventricular outflow tract. You can see this is the LVOT. This is a part of the left ventricle here. As we see here, this is the aortic valve leaflets, cusps, I mean. This is the aortic sinuses, and this is the ascending aorta, and this is the anterior mitral valve leaflet. If we are going to take this to the QLab of our machine, we can check the size of the aortic annulus, and we can measure the aortic annulus diameter precisely using the multiplanar analysis of the left ventricular outflow tract. And the same thing, the multiplanar analysis can be applied at the level of the aortic cusp depth, and we can get a direct measurement of the aortic valve area. Aortic valve stenosis in special circumstances. As you see here, this is a parasternal long axis of a patient and a short axis. This is a heavily calcific valve, aortic valve, pointing to the presence of aortic valve stenosis. And as you see here, there is global hypokinesia of the left ventricle, as seen in this long axis and the short axis. So this is a case of aortic valve stenosis with a reduced left ventricular function, I mean a reduced left ventricular ejection fractions. This could happen secondary to the aortic stenosis itself, or the aortic stenosis could be mild, but this low ejection fraction could be secondary to associated cardiomyopathic changes or due to the presence of a concomitant coronary artery disease. This situation is known as a low flow aortic stenosis secondary to a low ejection fraction. We call it a low flow, low gradient aortic valve stenosis, because whenever we have a reduced ejection fraction, as we can see here, the stroke volume is going to be low, and we expect that the gradient, whether the peak gradient or the mean gradient, is going to be low, and the mean gradient in such cases is going to be less than 40. But the aortic valve area, if you are going to check it or get it by the continuity equation, it's going to be less than 1. So we have here a severe aortic valve stenosis because the area is less than 1. But the mean gradient is low, so we call it a low flow, low gradient, severe aortic valve stenosis. And the reasons why the gradients are not high is the reduction in the global left ventricular systolic function. So, as I mentioned before, how to differentiate between a true aortic valve stenosis with a reduced ejection fraction versus a bad ejection fraction secondary to cardiomyopathy or concomitant coronary artery disease, but there is a pseudostenosis. I mean by pseudostenosis is that the poor contractility will not open the aortic valves so widely, so they appear to you as stenotic valves. To do this, we should go for Dobutamine stress echo. If we do, we are going to do to put the patient on a low dose Dobutamine protocol. We are going to stress the myocardium, looking for a contractile reserve. And a positive contractile reserve means that the cardiac output and the stroke volume is going to increase by 20% or more. So in our cases, whenever we are going to put a patient on a Dobutamine infusion at a low dose, we are going to expect an improvement in the contractility, and the cardiac output and the stroke volume are going to increase. So if we are dealing with a true aortic valve stenosis, we are going to expect that the gradient is going to increase and the aortic valve area is going to remain low or small or even becomes worse. So this is a severe true aortic valve stenosis. On the other hand, if the gradient of the aortic valve with Dobutamine increased a little bit, but the aortic valve area is going to improve because you are going with Dobutamine to improve the stroke volume. So what the leaflets which are appearing as pseudo-stenosis, they are going to separate and the valve area is going to increase. So in such a case, this is a pseudo-aortic valve stenosis. Going to the management of patients with aortic valve stenosis. We are going to check for the severity by the echo, looking for the maximal velocity and aortic valve area. And we are going to ask the patient about the symptoms of heart failure, angina, and syncope. And on the echo, we are going to check for the LDV response, how far the ejection fraction is doing, and there is any left ventricular hypertrophy or not. Check for the other valves, particularly in rheumatic patients, and look for the high risk features that I told you before about them, and to check for comorbidities and general condition and to assess the general condition of the patients. So the management options we have for symptomatic patients with aortic valve stenosis are the medical therapy, aortic valve replacement, and if your patient is not symptomatic, I mean the patient is having severe aortic valve stenosis, but there are no symptoms, sometimes the decision needs further additional testing. Going to the symptomatic patients with symptomatic aortic valve stenosis. When to put the patient on medical therapy, I mean no interventions, no surgery, no TAVI. Medical therapy should be applied to those patients with severe comorbidities when the intervention is unlikely to improve the quality of life or the survival of the patient. Because here, surgery or interventions will not affect the quality of the life and the survival of the patient, so no need, and we'll keep him on medical therapy. Then, who are those severe aortic stenosis and they are symptomatic? Those patients should have aortic valve, should have an intervention, I mean a valve replacement or TAVI. Class 1 is for those patients who are having symptoms and having severe aortic valve stenosis with a mean gradient more than 40. This is a class 1 recommendation. The second class 1 recommendation is surgery is indicated in asymptomatic patients, but whom? Those who are a reduced ejection fractions. So surgery or TAVI or intervention should be kept for those who are symptomatic class 1 and should be applied to the asymptomatic whenever the ejection fractions is below 50 millimeter. Also, surgery should be applied or considered in symptomatic patients with low flow, low gradient aortic stenosis and a reduced ejection fraction without contractile reserve on Dobutamine. When the CT calcium scoring confirms severe aortic valve stenosis, this is a class 2A. Also, intervention should be considered in patients with low flow, low gradient aortic stenosis with normal ejection fractions after careful confirmation of the severe aortic stenosis, and this is a class of recommendation 2A. Going to the asymptomatic aortic valve stenosis. So if we have a severe aortic stenosis and the patient is asymptomatic, no heart failures, no angina, no syncope, then when to intervene? The ejection fraction. Whenever the ejection fraction starts to decline below 50 in asymptomatic severe AS, we should consider the doing intervention for him. Number two, if the ejection fraction is even preserved, we are going to expose the patient to an exercise stress test. If you have abnormal exercise stress test in asymptomatic severe aortic stenosis, consider to have intervention in such patient. This abnormal exercise response could be the symptoms of heart dyspnea, angina, or syncope at the peak exercise, or a hemodynamic change in the form of a fall or a low blood pressure during lowering of the blood pressure during exercises. To add to this, if the patient is having severe aortic stenosis, he is asymptomatic, ejection fraction is okay, the stress test is negative, we can consider surgery in those high-risk aortic stenosis patients. So these are the recommendations for this. As you can see here, it's a class 1 indications, asymptomatic severe whenever the ejection fraction is less than 50, or those who are severe aortic stenosis asymptomatic, but they have symptoms during exercise stress testing, and those who are having abnormal hemodynamic response during exercise stress testing. And as I told you before, those asymptomatic with normal ejection fraction, negative stress test, low surgical risk, but they are considered high-risk aortic stenosis. We can do intervention for them. If the aortic stenosis peak velocity, Vmax, is more than 5.5, the rate of progression is more than, in the velocity, is more than 0.3 meter per second per year. If you have a raised BNP levels more than threefold for the age and sex, and if your patient developed pulmonary hypertension with a predicted pulmonary artery systolic pressure more than 60 millimeter. This is a recommendation class 2A. And thank you very much.